Now, with dynamic auscultation, things that you want to pay attention to. Altering heart sounds by changing circulatory hemodynamics. Oh, we'll be spending time with this. You've heard of hand grip. You've heard of, watch this, I'm going to disappear for 1 second. Whoop. What did I do? Rapid squat, right? So these are some of the changes, or these are some of the maneuvers that we will be conducting, or you'll be asked about. And depending on the maneuver, well, how is that going to affect or influence the heart valves and heart sounds? Is that clear? Now, this can be separate, but clinical, we're going to use some of these depending on what you're trying to confirm for diagnosis. And once you understand the physiologic alteration, then you've got your diagnosis. Let's continue. Before we even get there, though, let's make sure that we understand the difference between preload and afterload, please. Okay. Now, how do you increase your venous return? Well, we'll talk about those maneuvers coming up. But if you were to increase your venous return, to where? To right atrium, to right ventricle. What have you done to preload? You've increased the preload. What does preload mean to you? Preload means that it is the amount of fluid or volume within the heart. Okay? So if you increase your venous return, for example, if you were to constrict the veins, if you constrict the veins, are you picturing this? Not the arteries, but the veins. The veins are a major pooling area. If you constrict the veins, you're increasing venous return to the right side. Well, what are you doing to preload? You're increasing it. It is that simple. Preload is the volume of blood in the ventricle. Now, what if you decrease the venous return? Well, if you decrease the venous return, volume of blood into right atrium, right ventricle, such as standing up. If you go from supine position to standing up, whoop, then where's my blood? In the dependent areas. It's down in the lower extremity. What happened to venous return? It decreased, didn't it? So you have decreased preload. Now, what is the definition of afterload that you want to know here? Because this is important. Afterload is when you have increased resistance that the left ventricle is facing. Period. Period. The left ventricle, when it faces increased resistance. Give me some examples. Aortic stenosis, coarctation of aorta. And tell me about the arterioles. Take your time. What state are the arterioles in which it would then provide increased resistance to the left ventricle? Did you listen to my question? What state is my arterioles in providing increased resistance to the left ventricle? Constriction. Arterioles are the most important component or contributor to resistance, as you know, especially TPR, total peripheral resistance. If you constrict your arteriole, what happens to TPR? Increase your TPR. What then happens to afterload? You increase afterload. Are you seeing this? So afterload is that simple. It's the resistance that the left ventricle is facing, period. And I just gave you a bunch of differentials. Or they again, aortic stenosis, coarctation of aorta, and arteriolar vasoconstriction. Continue. Now let's talk about those action maneuvers, and we will go through the pathophys here. Deep inspiration. Okay, so what does that mean to you? Let's all take a deep breath. You with me? Good. What then just happened? The diaphragm contracted. Which way did it go? Downwards, right? What happened to abdominal pressure? Increased upon deep inspiration. What happened to thoracic pressure? It decreased. Literally became a vacuum. It's going to suck up, like a straw. It's going to suck up the blood into the heart. What's my topic? Increased venous return upon deep inspiration. Is that clear? When you have deep inspiration, increased venous return to the right side, what then may happen to the intensity of the murmurs on the right side? It would obviously increase. Clear? Next, supine position versus standing up. If you're supine, which I hope that you're not in right now, because if you were, there's every possibility that you're falling asleep. Supine position would be lying flat. You're lying flat. So therefore, you're making it easier or more difficult for blood to return to the heart. You're making it easier, right? And that's our topic, increased venous return, supine position. What if you went from supine to erect position? The blood then drops where? Down to the legs. So you decrease your venous return. It is that simple. Passive leg elevation. You pay attention to this. Same thing here. So you're going to raise your legs, and when you do so, then what happens? You're going to then return the blood to the right side. Clear? Increased venous return. Rapid squatting. Now, this is important. There are two major issues that you want to pay attention with squatting, please. Here, I'm going to do this quickly. Whoop. Okay, I just think of me just rapidly squatting. When I did so, then I increased the venous return. Boom. Here comes more blood. Okay, that's one example here that you may want to think about clinically. Now, what about if this was a child? And what do children like to do? They like to play. They like to go run. Hey, mommy, can I go play? Of course you can, right? So the child wants to go play. And then all of a sudden the child is playing and can't breathe or having a hard time breathing. And the child really instinctively is going to do what? Whoop, squat. Now, what's the diagnosis in this patient in which after playing for a little bit, the child instinctively knows to squat? It's called a TET spell. So what's happening there? So what I'm going to do for you here is make sure that we delineate the two different type of squatting maneuvers, and depending as to what you're trying to confirm is going to give you, well, different types of diagnoses. If it's rapid squatting, yes, it does bring about increased venous return. But tell me about that patient, the child who just squatted when the child was feeling a little cyanotic with a little hypoxemia. It's the fact that there might have been what? There might have been pulmonic stenosis, number one. Number two, there might have been right ventricular hypertrophy. Number three, there was what? Ventricular septal defect. Number four, there was overriding aorta. What am I referring to? Obviously, tetralogy of Fallot. Tetra. 4. And what kind of shunt is this? It's a congenital cyanotic heart disease, a right-to-left shunt, right from the beginning. Because the right ventricular hypertrophy is then shifting. What kind of blood is in the right ventricle? Oh, tell me. Ah, good. Deoxygenated. And that right ventricular hypertrophy is pushing the blood through the VSD into the left side. What kind of shunt? Right-to-left shunt. So what do we have? Cyanosis. Who's feeling it? The child is. So what's the child doing instinctively? Squatting. To do what? Not to increase venous return. So why is the child squatting? To increase TPR. How do you do that? You increase TPR by constricting the arterioles. Well, I just got done telling you what happens when you increase TPR. You increase afterload. When you increase afterload, who's facing increased resistance? The left ventricle. And so therefore, what happens to the shunt? It gets reversed. Instead of right to left shunt, that type of squatting with tetralogy flow will then turn into a right to left shunt. Now, is this the only time that we'll see it? Not at all. Talked about this in embryology. We'll talk about this further as we get into congenital heart disease. Why am I bringing this up? Because you must be very clear about the issues of squatting. Let's continue. Now, let's talk about Valsalva. What are you doing? Don't laugh, but if you must, so be it. Looks like I'm constipated. What am I doing? I've closed my epiglottis, phase 2, and that's what you pay attention to. So when you're expiring against a closed epiglottis, what happens to thoracic pressure? You've increased it. Good? You've increased your thoracic pressure. Initially in phase 1, what did you do to your pulmonary capillaries? Whoop! You closed your pulmonary capillaries. Would you tell me as to what's distal to the pulmonary capillaries? I believe it's the left atrium. Correct. And by quickly closing pulmonary capillaries, you increase venous return to the left side, but that's not the point. The point here is during phase 2. If you continue to squeeze your pulmonary capillaries, there isn't any more blood in there. Look, there's no more blood in there. So what will happen to venous return? It decreased. Are you with me? If you continue to squeeze because of that increased expiration against the closed epiglottis, then at some point you're going to decrease venous return, and that you must pay attention to, because that becomes important to us as we get into valvular heart disease, and at that point, I will repeat this very point. Well, let's go from supine position to standing up. So you stand or sitting up quickly, then what then happens? The blood then rushes down into your legs. What happens to venous return, ladies and gentlemen? It's going to decrease. There's your blood down in the feet. It's not in your heart. Now, you take me one step further. What did you learn in physiology already? You heard about baroreceptor reflex, huh? Baroreceptor reflex. What are they located in, these baroreceptors? They're located in your sinuses, aren't they? Which one's more sensitive? The carotid aortic sinus. The carotid sinus, because it's not accustomed to large amounts of blood like the aorta is. The aorta is accustomed to large amounts of blood. It's not as sensitive. The carotid has glossopharyngeal. The blood has then gone where? Down into legs. Then what happens? Stretch. Decreased stretch. When you have decreased stretch, what happens to firing? Decreased firing. My blood has then rushed down into legs. What kind of outflow do you want from the autonomic nervous system, please? Good. Sympathetic. That's exactly what's happening. It's called the baroreceptor reflex. You're going to be asked about this? Guaranteed you will. In many places. All right, now let's take a look at these other maneuvers that then will help you diagnose your patient, I want you to take your hand and I want you to clench your fist and I want you to come at me right now because, Dr. Raj, you're driving me crazy. You're frustrating me. You're giving me all this information. I just want to hit you. Okay, so you clench your fist. You with me? So is that your sympathetic system? Of course it is. So when you do a hand grip, it's sympathetic nervous system because you're angry. Oh, calm down. It's okay. If you have a stress ball, probably a good time to grab it, right? So there you are. You're squeezing it. And what have you done to your arterioles? You've constricted it. What have you done to your TPR? You've increased it. Once again, when you increase your TPR, what have you done? Are you affecting your afterload? Yes, you are. And what have you done to your afterload? You've increased it. Why is it important? You shall see. And I'll keep coming back to this point where you have understood by increasing that afterload, then where's my blood? In the left ventricle. It's having a hard time getting out of the left ventricle, and you shall see, and you'll understand why in aortic stenosis, when you do a hand grip, what happens to the intensity of the murmur? Decrease. Don't worry, we'll talk about it again. What about exercise? With exercise, once again, you've talked about this in physiology. What is it going to do to your arterioles? What was my question? What is it going to do to your arterioles? Vasodilate. It has to. Why in the world would you want to increase your TPR in exercise? That makes no sense. You want to make sure that you have vasodilation so that you properly oxygenate your tissues. Clear? In the meantime, what's happening to your veins in exercise? Vasoconstriction. The combination of the two, well, what do you know about cardiac output? You might go from 5 liters, you might have increased by 100% to 10 liters. That's amazing doing exercise. But what about blood pressure? It doesn't change much. Why? Because of vasodilation and vasoconstriction. And so therefore, the combination of the two will keep your mean arterial pressure approximately normal. Is that clear? It's amazing. Exercise is a beautiful phenomenon. And the more that you know about it, the more number of questions that you'll get right. In this case here, increased flow across your valves.